the practical application of the SANO in an Indian context, it would slowly happen because the rectal cancer data, for example.
The OPRA trial is same, very similar.
Slowly we are getting into it. It takes much longer time than most of the places, but because in rectum the worry is stoma, LARS,
Yes.
and things like that. Here, mortality is significant.
Yes.
Morbidity is also there, which doesn't get so much attention because of the mortality.
Yeah.
And unless you have, and high volume centers are not easy in esophageal surgery, unlike rectal surgery. Rectum, it's easy to generate make a high volume center because the disease is much rarer. So dysfunction, mortality, both are significant. So it will slowly catch up. Yes. Right now we tell the patient if they are ready for all the risks, we send them for chemoradiation and then ask them to continue if they cannot make up their mind for surgery. So it's not within a protocol, but it does happen.
Yes.
We keep patients on follow-up. Stringent follow-up is also very expensive here. So multiple factors.
Excellent point. That's very relevant to comparing to the rectal cancers to the esophageal cancers. As you know, the morbidity and mortality is much higher in upper GI
Absolutely.
compared to the lower GI because of the malnutrition aspect.
Yes.
And following them up for long term could be difficult.
Yes.
If I'm allowed to speak, I think another important factor which is completely different in how we are practicing today in esophageal cancer is one is all adenocarcinomas are now not receiving cross but receiving FLOT. And now FLOT with durvalumab. And that's where adenocarcinoma is going. And a predominant, if you see the number of adenocarcinomas that were included in SANO, it was a significant number. So that's A. B is, as Taste also said, 90-day mortality is higher in the salvage surgery arm, which is not similar to rectum. 3, no immunotherapy of any kind was allowed in SANO trial. So the standard practice today is if after surgery in a squamous, patient who has received neoadjuvant chemoradiation then surgery and has not received pathological complete response, they are put on immunotherapy. So you are giving the benefit of doubt to the biology and maximizing oncological therapy based on the response seen after surgery on your final specimen, which you cannot do in a wait and watch final approach, which is why the rate of distant mets was high in the arm there. So the next trial, which is SANO 3, has included immunotherapy in it. And that would tell us that if you give neoadjuvant chemoradiation with immunotherapy, and then if you achieve CCR and you wait, what is the problem? So the neoadjuvant chemoradiation in its own is not a very strong therapy for systemic control. It's great for local control. So we need to intensify the systemic therapy in the neoadjuvant chemoradiation arm.
All points are absolutely well taken. I think we'll be covering these issues in my talk in the next session. Of course, each trial was designed in its own era, and by the time the trial results come, the evidence evolves and goes ahead, and you get new treatment paradigms by the time the trial is published. But also, having said that, the trial data stands as it is, and we know that patients who achieve CCR definitely they can be offered the option of active surveillance.
Can I make a small comment?
Absolutely.
From the perspective of the endoscopist, about 10 years back, 15 years back, when we had this option of putting patients of squamous cell carcinoma after radiotherapy or chemotherapy on surveillance only, at that point in time, the problem was the endoscopist's miss rate of residual tumor was close to 40% or 50%. This is publications about 15 years back. And the SANO trial, I think it was predominantly Dutch centers and some German centers. I'm not sure UK was included there or not, maybe a couple of centers there. What they did was they changed the endoscopy, the way biopsies were taken, the way surveillance was done, to what is described as well biopsy. Of course, I'm a surgeon, I have no idea how it works. But they specifically said that we have made a protocol and tested that protocol and increased the sensitivity of endoscopy for residual disease from 60% to 95% with this protocol, whatever that means. That is how the surveillance worked. The problem is SANO trial is almost, the recruitment was almost 10 years back now. It's almost outdated completely. And it's outdated not only in terms of immunotherapy, but also in the way endoscopy was done. Because that's what I wanted to know from your study. All those tools which you're using today for early tumors, could they have been used or will they be used subsequently to pick up residual disease and have a negative miss rate of close to 99% or whatever that means? Because if you are going to put the patient on surveillance, the bottom line is endoscopists should not miss a tumor. Surgeons cannot pick it up. The PET scans can easily miss tumors because micrometastases are very poor. So the only way you can pick up residual tumors in that surveillance protocol is endoscopists getting his act together in ways which you described and the way their trial described. That was actually my question when I asked you about the new post-neoadjuvant residual tumor assessment and so on and so forth. FLOT has already been tested against cross and found that FLOT is better for adenocarcinoma. So you could assume that this will become even more dominant because if FLOT has better response, more and more patients would enter a protocol which is for surveillance rather than the other way around. Because patients have a complete response rate which is higher than cross, you have more and more patients coming back to the endoscopist saying, do I have tumor or not? So I'm not sure how it works. Of course, immunotherapy and of course SANO 3 will take this further and it will keep on evolving. But my assessment is that this is going to become a surgical problem. Ultimately, the surgeon decides whether I should operate this patient or, as the patient says, I'm all right, should I send the patient to the endoscopist? Because then you're relying on the endoscopist to say there is tumor, there is no tumor.